Right, I think we should be okay to start now then. Good afternoon, everyone. Welcome to the post-lunch session on cervical degeneration. I'm Ash Khurana. I'm a consultant spinal surgeon at Royal Gwent Hospital in South Wales, Newport, and with me is Callan. I'll ask Callan to introduce himself before we move on to the first talk.
Hi, welcome, folks. My name's Callan Matheson, one of the consultants in Glasgow. Hope you enjoy the next half hour.
Thank you, Callan. So the first paper is by Yi-Hu Xu. Does the preoperative inferior end plate morphology influence outcomes of cervical disc arthroplasty at C5-6 level? Retrospective review. So we'll invite Yi-Hu Xu for that, please. Thank you.
Hello everyone, I'm Hu Xu from Western Hospital. My talk today is that preoperative inferior end plate morphology influences the outcome of cervical disc arthroplasty at C5 and 6 level, a retrospective study. As for geometry of inferior end plates, we did some anatomic measurements previously. On mid-sagittal plane, we classified inferior end plates to 3 types. From type 1 to type 3, the concave apex moved from posterior to anterior. It was reported that endoplate morphology may influence the clinical outcome of lumbar disc arthroplasty. So, bearing this in mind, we wanted to explore the effect of preoperative inferior endoplate morphology on the outcome of CDA. We did a retrospective study of C5 and 6 level CDA patients. These are inclusion and exclusion criteria. Based on CT data, inferior endoplates were visually classified into 3 types according to the position of concave. We measured the range of motion and the cervical alignment preoperatively and postoperatively at 6 months, 12 months, and the last follow-up. Clinical outcomes were evaluated by GOA, NDI, and VAI scores. In total, 132 patients were included, with 33, 68, and 31 patients in each group. The mean follow-up time was 33 months. Baseline data were comparable. Patients achieved significant improvement in clinical outcomes without substantial differences among 3 endoplates. On radiological outcomes, segmental and global ROM were preserved. Compared with preoperative values, the C2 and 7 angles were preserved, while the C5 and 6 angle increased significantly from kyphosis to lordosis. Notably, at the last follow-up, type 1 endoplate had the least C5 and 6 angle, and the type 1 endoplate had the highest incidence of segmental kyphosis at surgical level. We speculated the endoplate preparation may be the possible interpretation. Mismatch in shape between concave endoplate and a flat footprint prosthesis would result in limited contact, eventually causing interfacial gap and increased contact force. Thus, to maximize the contact area, we preferred to melt the anterior inferior part of the superior vertebra relatively more. By this operation, interfacial gap would be largely eliminated. For type 2 and type 3 endoplates, only a small portion of anterior part should be removed. But for type 1 endoplate, a relatively larger portion of the anterior part require removal, which might change the vertebral shape and alter the stress transmission, eventually contributing to the postoperative kyphosis. In conclusion, Patients achieved satisfactory clinical outcomes after C5 and 6-level CDA without significant differences among 3 endoplate types. Type 1 endoplate had a high incidence of segmental kyphosis at surgical level. Thank you.
Thank you, Ihoshu. Could I invite all the attendees to put their questions in the chat box? The chat is moderated, and we would ask the questions once all the 4 talks of the session are done. So if you could please put your questions into the chat box. Next, I would invite Dr. Naresh Kumar, and his talk is an RCT comparing the efficacy and safety of ProDisc implant to the ACDF in treatment of cervical degenerative disease.
Hi, I'll be presenting the first randomized controlled trial comparing the efficacy of cervical TDR and anterior cervical discectomy infusion in symptomatic cervical disc disease. As we know, ACDF is a gold standard for treating cervical disc disease. It is however, fraught with the problems of adjacent segment disease or adjacent segment degeneration. In order to address this, we have the cervical TDR, which is well established through a number of prospective randomized trials and prospective studies presented in the West, and which is the European study or the American study. ProDisc is a cervical TDR which is well established. The current literature only looks at the literature from the western part of the world. We know that the race is an important factor, and it affects the complication rates, length of hospital stay, mortality, and hence I think there is a place for looking at a prospective study using TDR versus ACDF in Asian population. The study design was a prospective randomized controlled trial where we wanted to show non-inferiority of ProDisc TDR compared to ACDF. It involved 9 sites, 5 countries. The study was initiated in January 2008. It was a block randomization, 2:1 in favor of ProDisc, and the patients and surgeons were blinded until the surgery. This is a busy slide which shows the inclusion and exclusion criteria. The important thing to mention here is in 2010, the protocol was modified and patients with myelopathy were included. So patients with JOA scores of 13 to 17 were also included in this study. The outcome assessments were clinical, which is the NDI, neurological assessment, SF36 VAS, and adjacent segment degeneration, looking at the KL scale, radiologic assessment, and safety assessment as mentioned here. The time points of assessments are mentioned here, which is 6 weeks, 3 months, 6 months, 12 months, 18 months, 2 years, and on a yearly basis up to 7 years. However, the study was terminated due to lack of funding from DePuy-Synthes. The primary endpoint included a composite score using the 4 factors mentioned here, and it was supposed to have an overall success at 24 months, must have had a improved primary endpoint. There were some secondary endpoints which we have mentioned on the slide. We can see that the patients who were randomized were 80 to 40. And finally, we used only 68 patients in ProDisc group and 33 in the ACDF group for assessment. There were no significant differences in the demographics. There was some higher amount of blood loss in the ProDisc group. There was no significant difference in the postoperative complications. As far as the overall success was concerned, there was no significant difference in the 2 groups. Non-inferiority was proven only at 3 months and 18 months for the whole group. If we excluded myelopathy patients, the non-inferiority could be proven at 3, 12, 18, and 24 months. There's no significant difference in clinical outcomes of ProDisc and the ACDF group, as we can see on this slide. There was, again, no significant difference when we looked at the secondary endpoints, which we have already mentioned in our previous slides. The plausible reason for no clear non-inferiority would be the fact that there were higher number of myelopathy patients in the PRODIST C group, or the fact that there was a variation in study design halfway during the study, or the fact that the ACDF group, which was the comparator, was different than the American standards, which was plate cage system. In conclusion, we can say that cervical TDR with PRODISC is a feasible and a safe option for treatment of cervical disc disease, which includes both myelopathy and radiculopathy. There is no clear non-inferiority between the two methods of treatment. The long-term follow-up may demonstrate lower incidence of ASD in the PRODISC C group. Thank you.
Thank you, Dr. Kumar. That was great. That leads us to our third talk of the session, and that is by E. Hoshu again, clinical and radiological outcomes of single-level cervical disc arthroplasty in patients with preoperative reversible kyphosis, a matched cohort study.
Hello everyone, I'm Hu Xu from West China Hospital. My topic today is clinical and radiological outcomes of single-level cervical disc arthroplasty in the patient with perioperative reversible kyphosis, a matched cohort study. CDA is a promising new technology for refractory cervical disc degenerative disease, but the performance of CDA in the spine with more alignment was unclear. Kyphosis was reported to be a contradiction for CDA in most literature, due to the lack of anterior column support, prebent plate, and little ability to restore cervical alignment. However, it was also reported that modified techniques could prevent the imbalance of cervical spine, and some artificial discs could restore cervical alignment to some extent. The purpose of this study was to report the clinical and radiological outcomes of single-level CDA in the patients with perioperative reversible kyphosis, and compare these results with those of a matched cohort with perioperative lordosis. We did a retrospective study of single-level CDA patients. Cervical alignment was determined by C2 and 7 angle. Reversible kyphosis was defined when overall kyphosis on the neutral radiographs was spontaneously corrected to lordosis on extension radiographs. We did follow-ups and evaluated clinical outcomes regularly. Radiological parameters, including ROM, cervical alignment, and HO, were also measured. 36 RK patients were matched with 229 lordosis patients, according to the same follow-up time and the surgical level. Baseline data were comparable. Patients achieved significant improvement in clinical outcomes without substantial differences between groups. Before surgery, lordosis group had significant grades C2 and 7 angle, SC and FSU. Compared with perioperative values, RK group experienced significant improvement in C2 and 7 angle and SA after surgery. While in lordosis group, C2 and 7 angle, SC and FSU were maintained. At the last follow-up, the intergroup difference of C2 and 7 angle, SC and FSU remained significantly. IOMs were preserved in both groups. The IOMs of RK group were slightly lower than that of lordosis group, but failing to reach significance. Notably, there was a significant greater incidence of high-grade or IOM affecting HO in RK group. Looking at this case, the cervical alignment improved from kyphosis to mild lordosis after CDA, but at 5-year follow-up, the segmental ROM at surgical level nearly vanished with a grade 4 HO being noticed. We speculated the design of prestige LP discs and the plate preparation and sufficient decompression were the contributing factors to the increase or restoration of cervical alignment. In conclusion, both RK and lordosis groups achieved satisfactory and comparable clinical outcomes after single-level CDA, despite the
Should we move on to the next one if this one's not working?
improvements compared with preoperative values. The cervical alignment of RK group was still inferior to that of lordosis group. More HO formation occurred in RK group. Thank you.
That's great. Thank you very much. I thought it was working fine. Was there any issues? Callan, I thought it was working fine.
Sorry, it didn't work at all for me there. I couldn't see anything. Apologies if everybody else was seeing it fine.
Yeah, I think everyone else was okay. It was playing this end as well.
Okay.
So we shall move on to our next, and that is the last talk of the session, and that's by Dr. Balakumar Balasubramaniam. Is there an argument for implant-related cost reduction in ACDF? A retrospective comparative review of complication profile between peak cages and zero peak cage screw construct.
Good afternoon, everyone. I'm Balakumar, orthopedic trainee from Birmingham Rotation. I'll be presenting this paper which compares the complication profile between peak cages and zero peak cages which were used in our institute. We all know cervical disc disease leads to radiculopathy and myelopathy, with ACDF being the gold standard for treatment, which was initially described with cortical bone graft and plating. With the advances in implant science, the bone grafts are getting replaced with cages, like a standalone cage or a cage screw construct, with the cage screw construct showing promising results in terms of improved sagittal alignment parameters, decreased incidence of subsidence and dysphagia. We wanted to see if these two implants had any difference in terms of complications and the outcomes from our own data. So we looked from August 2016 to July 2018 and found 162 cases which met the inclusion criteria, of which 83 patients had peak cages and 17 had zero peak cages. We looked at their case notes to look at the ODM score, which is based on the pain and the activities of daily living. Also, we looked at the radiological assessment in terms of fusion, subsidence, and sagittal alignment parameters. These are the statistical tests used in this study, which were done using SPSS 24 version. There was a fair distribution of cases between the sexes with an average age of 52 years and a mean follow-up of 9 months. And we could see 105 cases at the single level and 57 cases with multi-level surgery, with an overall 222 levels assessed in this paper. Of the myelopaths, 27 patients showed improvement in symptoms, but 14 myelopaths had stabilized symptoms and 7 patients had worsening of symptoms, of which 5 of them needed posterior decompression. 1 didn't show any further compression to go for further surgery, and 1 waiting for surgery. In terms of complications, the difference observed between the groups did not reach statistical significance for all the observed complications, like transient swallowing problems, transient hoarseness of voice, cage migration, delayed union, Horner's syndrome, CSF leak, adjacent segment disease, and documented subsidence in case notes. We could find more smokers in the standalone group compared with the cage screw construct, and the sagittal alignment parameters observed between the two groups did not show any significant difference, and the overall complication rate also did not show any significant difference. We looked into a multivariate regression to see the following covariates if they influence the result, like gender, age, fusion, subsidence, smoking, and Charles Comorbidity Index, and ODM score. We did not find any difference between the groups overall and also at single and multi-level. Within this study, we didn't find any complication difference between the two groups, and the outcomes were comparable, the sagittal alignment parameters including. And to the best of our knowledge, this is the first series to report complications at a multi-level for these two implants. 0P has been found to be a bit expensive than C-space, and we could see a potential saving of at least 100,000 pounds for NHS on an annual basis. However, given the retrospective nature of the study, there are limitations, including variable follow-up duration and a smaller sample size. We think within the limitations, we didn't find any difference between the two groups, and we propose to do a prospective assessment of the same two implants with an adequately powered study to confirm our results. Thank you very much for your attention. Thank you.
Okay, thank you for the talks. Thank you, Helen, for moderating the chat. And I would, if Helen, if you could have all the presenters in our presentation areas so that they can field the questions, and Helen could put the questions to them, that would be great.
Yeah, unfortunately, we only have Balakumar in the audience. The other presenters aren't in the audience.
Right. So we will just ask Balakumar the questions relevant to his talk in that case. I don't think any of the answers are there on the chat box as well. Okay. Over to you, Callan.
Thank you. Most of the questions so far have been for the other three presentations, and unfortunately. Some of the questions were quite interesting as well. From Nick Newell regarding the first presentation on the differences at end plates, different implants for each of the different types described. I would have been quite interested to hear about that. Do we have Balakumar available now? Camera's not enabled. Can you hear us?
It's in there ready and the mic's on, so should be able to answer.
Hi, Bala. So the question we've got here so far is, was a cervical collar used in the standalone group? Having some difficulties, unfortunately, with that. Any of the other people that are involved in the papers, Helen, in the room?
I don't have that information, unless, so I can't search the audience.
If you could, I don't know, if any audience members could say, maybe put it in the chat if you're willing to. Oh, here we go. We've got Mr. Hassan here stating no collar used in any group.
So is Balakumar not with us now, is it? He doesn't seem to be in the presentation area.
Oh, he's just said his camera is not enabled.
Right.
Oh, he's gone now. Let me try again.
Yeah, see if the audio works. That would be fine as well.
Hey, I think I was just trying to call you back. Sorry. What's it?
Balakumar stated that he's not able to log on.
Okay. Well, unfortunately, not many answers to those questions then.
Yes, unfortunately, we have none of the authors are unfortunately able to comment.
That's the gift of technology.
Well, perhaps we would draw this to a close then, slightly earlier than anticipated, a few minutes earlier as a result of that. I'd like to thank the speakers for their clear presentations, and thanks, Helen, also for your technical support. Oh, do we have something?
Balakumar has just joined. I can see him on the area here. So let's see if we can.
Hi, Bala. We've got a few minutes. Thanks for joining us. Microphone on, working okay? I can't hear you, certainly. Can anybody else hear him?
No, it doesn't look like he's working.
Okay.
Can you hear me now?
Oh.
Yeah, very faintly, yeah.
Okay. Hello?
Yes.
Sorry about this. There was a technical issue on my side. I think my browser was not allowing me to start the video or audio.
No trouble at all. So one of the questions that was asked was a cervical collar used in the standalone group?
So yeah, that's a good question. There was quite a bit of variation in the practice. It depended entirely upon the surgeon. Many of the surgeons didn't use it. Few did use it. Even for multi-level, the consultant whom I worked with didn't use any collars. So to answer the question, it's quite variable and it's surgeon dependent. There was no standard practice in the unit. Like this is what is the common post-operative protocol. It varied by surgeon's preference.
Okay. Unfortunately, the video didn't work for me, but I have reviewed it previous to today. One of the questions I wondered: do you have something in your heads that you'd use one of the a cage for certain cases and ones with screws for a different type of case?
No, the cage and screw construct, again, it depended on the surgeon. Some surgeons preferred cage screw construct and few did a standalone cage. Again, there was no specific indication to use one implant or the other in our study group.
Okay. And from memory, was there an increased risk of dysphagia in the peak group? Did I ever remember that correctly?
Yeah, that's a good question, actually. The study is just based on the data from what's recorded on the clinic follow-up notes. So if it is recorded, we captured it. If it's not recorded, if the patient didn't, if the person who saw the patient didn't document it, then we don't know. So it would be difficult to say exactly if it is more or less, but within the documentation levels, I could see that the standalone was showing more dysphagia than the cage screw construct, but they all were transient, and it was less than 4 weeks. Everybody resolved, and they didn't have any long-term problems. In terms of the statistical analysis, we didn't find any difference between the two groups. However, it's most likely due to the retraction during the surgery, because everybody resolved. And we didn't, unfortunately, document or find the duration of surgery for each patient. So I'm not able to do a subgroup analysis to see if this really made a difference.
Okay, that's good. Well, I think that's us at time, folks. So I'd like to thank all the speakers for their time, for their clear presentations. I believe we're moving straight on to the next paper session, which is on pediatric deformity. So I think we'll close it here, and I think you guys will stay in the room, and then the next session will take place.